But before we get into health and talking about health, let's first recognize Veterans Day. Let's recognize the veterans, those in the military that serve to protect our country, to provide freedom. And so I want to really, really recognize our veterans and those in the military. And thank you for what you do. And so today in Miami Community Health, we're going to talk about some neurological conditions. You know, even me as a physician, I've heard these conditions, but they've been obscure to me. I don't really understand what they really are and how they relate. And thank God I haven't had a family member or even a friend with any of these conditions, but we're going to clarify them. So I've brought our neurologist and our neuromuscular expert to talk to us about that. Dr. Varela, welcome.
Thank you for having me.
All right.
I appreciate it.
So first, obviously we know you're a neurologist. So tell us a little bit about yourself and what you do.
Yes, so I am a neurologist, board-certified neurologist, but also I hold board certifications in clinical neurophysiology and also neuromuscular disorders. So I trained at USF in Tampa, and then I did a fellowship at Mayo Clinic in Jacksonville. And then after that, I worked in academics for a while. So then I worked in private practice. Now I transitioned to pharma, but then I still have my practice part-time. And I work at the hospital. I'm affiliated with Baptist and West Kendall. And so doing a few things, but trying to help.
Busy. Sounds like busy, busy. So obviously you have that expertise in neuromuscular disorders, and that's what we're going to talk about. Correct. And so neuromuscular disorders in just general terms, what is that?
So that's a disease. Those are disorders that affect the peripheral nervous system, the junction between the nerves and the muscles and the muscles. So it is a different type of family of disorders, if you will, compared to central nervous system disorders, which include Alzheimer's, Parkinson's, strokes, or seizures. So they are common, although the topics that we'll talk about today are not that common, but they happen. And it creates confusion even among patients and physicians, the way it presents. So it requires a high index of suspicion and knowing what you're dealing with. So.
Wow. And that's why we're going to try to educate our population today and our public and our community. So God forbid you have a family member or a friend. So the first one we're going to talk about is myasthenia gravis. What is myasthenia gravis?
So myasthenia it's not a common disorder, but it's important to recognize it. So the way the patient presents, they have two different ages. So we have what we call a bimodal distribution. There are younger patients, usually women, that have what we call generalized myasthenia. And then we have older patients, mainly men, that have what we call ocular myasthenia. So this is an autoimmune disorder, meaning that the immune system doesn't act well, and then it starts attacking the junction between the nerves and the muscles. So the nerves supply the muscles to make them move, essentially. So that junction is very important. There are some molecules that are released from the nerve ending to the muscle, and then that tells the muscle, hey, you need to move. So whenever that is affected, then you can create problems with weakness, et cetera. So that's
and so what do people with myasthenia gravis are feeling? They're feeling weakness, or what are the symptoms?
This is a typical way we can recognize those patients. So the most important and most common presentation is double vision and droopy eyelids. And what is important about this is that they present mainly in the afternoon because the nerves release this molecule, as I said, it's called acetylcholine. And what that happens is that the more activity you perform, the more it is released. So if you don't have enough acetylcholine available to supply the muscle, then the patient can get tired later in the afternoon. So the muscles also are present in the eyes. That's why you get the double vision and the droopy eyelids. That's what we call the ocular myasthenia part. But then there is one that is called generalized myasthenia, where patients complain of weakness on the muscles of the swallowing, also the pharynx, so they have difficulty speaking, and also muscle weakness, mainly on the shoulders and the thighs. It's what we call the proximal muscle weakness. And it is fatigable or fluctuating, meaning that the patients tend to get tired after performing activities. For instance, in the eyes, they typically say, doc, I have this double vision and droopy eyelids after I read for a while, or after I watch TV for a while, or I'm driving, and especially in the evening. And also they complain of muscle weakness in the shoulders and thighs when they perform activities, when they exercise, when they go for a walk, etc. But the important thing is the fluctuation throughout the day. They are good in the morning and they get tired in the evening. So that's the classical hallmark presentation.
And then you talked about the age. Is there an age or a gender preference?
There is an age and a gender preference. For instance, we have recognized more often now that most cases of myasthenia occurred after the age of 65. And they're mostly men and mostly ocular presentation.
Okay.
But there is a younger population, especially women, that present with generalized myasthenia, meaning more involvement of the swallowing muscles and the muscles of respiration, and also the muscles of the shoulders and thighs.
All right, so I'm listening to you, or I have a family member, and I'm having the double vision, I'm having that fatigue, and I'm having these symptoms. What should that patient do? They should go see a neurologist like you?
Correct. So if the symptoms are mild, which in many cases it is, so the patient has double vision, droopy eyelids, it's fine to go to a neurologist's office and seek treatment and also diagnosis. But there is an important part of this. Sometimes myasthenia gravis can present in crisis, meaning that they have this rapid progression to severe difficulty swallowing, difficulty breathing, and severe weakness. So in that case, the patient should not wait to go to the neurologist's office in 2 weeks, in 3 weeks. So they should go to the emergency room right away. Why? Because they can decline very quickly. And if you're not breathing well, then you might require intubation, and mechanical ventilation too, and rapid treatment to avoid mortality. So myasthenia gravis has a very good prognosis when it's treated well, but you have to act quickly in those situations.
All right, so let's talk about the diagnosis. So whether we see somebody in your office or you see them in the emergency room with this very fast progression, how do you make the diagnosis of myasthenia gravis?
So the first test that we perform is something called acetylcholine receptor antibodies. It's a blood test that about 85% of patients that have generalized myasthenia, especially these younger patients, they can get diagnosed very easily with that test. And but there is still a 15% chance that those antibodies are not present, they're negative, and they still have myasthenia. So in those cases, you have to do other type of antibodies. And so you can cover all those patients. But in the ocular myasthenia presentation, which is more common, especially as I said, in older men, that there is only a 50% chance that those antibodies are present. So even if the antibodies are negative, then you have to sometimes treat the patient or do other tests. For instance, the test that we would do as a second step is an electrophysiological study. It's called EMG, nerve conduction studies, electromyography, nerve conduction studies. And there is a specialized test that we do that is called repetitive nerve stimulation to look for fatigability of the nerve and the muscle. And in those cases, we can make a diagnosis of those ocular myasthenia patients with negative antibodies.
And you can do an EMG on somebody's eye?
You can, actually.
Wow, okay, I did not know that.
Typically,
I'm thinking about the EMG on the arms and stuff like that, right?
It's more specialized, more difficult to do, but it can be done. And with enough expertise and experience, it can be done. So we can actually test the facial nerve, the nerve that involves the muscles of the face, and also the ocular muscles, because we can put a needle in the forehead and then test that muscle. There is an even more specialized test called single fiber EMG that is very sensitive. So if that test is negative, it excludes almost all patients that could have myasthenia. So that can be done as well.
And I didn't hear you mention MRI of the brain or anything like that. Is that not necessary?
That is an excellent point. Because at the beginning, sometimes this type of diseases can present in many shapes and forms. You know, it can affect any muscle in the body. So typically, this patient will get an MRI first. Okay, and especially if they go to the hospital, because if I see a patient in the office that has fluctuating droopy eyelids and double vision, many times I don't do the MRI first. I just go directly to the antibodies. But at the same time, I start thinking that perhaps if I'm not correct in the diagnosis, then I should have the MRI already ongoing. Yeah, that's an excellent point.
Okay, so somebody gets diagnosed with myasthenia. What is the treatment?
The treatment, we have different medications in the arsenal right now, and there are new developments that are very exciting because it can cover those patients that can be difficult to treat with the traditional treatments that we have. But if the patient presents with the mild disease, then we typically use a medication called pyridostigmine or mestinon. Mestinon is the brand name, pyridostigmine is the generic name. So it is a benign medication, it doesn't cause long-term side effects, and it can be very helpful in these patients. But eventually, most patients will go into develop more symptoms. And in those cases, you need to use what we call immunosuppressant medications. So the first one that we use is steroids, prednisone. And it's a very effective medication for myasthenia, and patients do very well. But as we know, all physicians that use steroids have long-term side effects.
And you keep them on steroids forever? They have to be on...
You typically start on steroids, and eventually you taper it down. So meaning that you decrease the dose over time to keep the patients on the minimum effective dose that in order to avoid this uncomfortable side effects, so high blood pressure, diabetes, bone problems, I would say
osteoporosis and things
exactly, like that. And wound healing issues that they can have, especially in surgeries. So it is important to try to use the least amount, the more effective medications, the steroid medications.
So basically, you said one of these medications that and then steroids we use.
Correct. Then the third tier here is the other immunosuppressant medications. So we have other stronger ones. So like azathioprine or mycophenolate mofetil is called Cellcept, that's the brand name. And those medications can be used long term with less, side effects. However, we have to be careful because those medications need to be monitored over time. So we need to do periodic blood tests to ensure that there is no decrease in white count, decrease in hemoglobin, that this doesn't affect the liver, the kidneys, and also watch for malignancies because these immunosuppressants sometimes can cause lymphoma, leukemia. So we have to be very careful. And that's why we need also other type of medications now that are available. There is one called efgartigimod, which is it's a very specialized medication to target a specific immune system pathway. And also there is another one called eculizumab, that those are antibodies, so monoclonal antibodies that actually they're called complement inhibitors. So it's very complex, but it's something that is also in the arsenal, especially for cases that do not respond to steroids. There are patients that are contraindicated to use steroids on, and so that can be used in those situations.
And what is the prognosis? I mean, both in the young woman and in the older man with the ocular, are they going to do okay? I mean, you've mentioned a lot of different medications. It looks like we have a lot of things in our arsenal. Is the prognosis good for myasthenia nowadays?
Prognosis for myasthenia is very good.
Okay, good.
The life expectancy is normal. But as I said, we have to have a high index of suspicion when the patient is, progressing very fast. In those cases, they need to be admitted to the hospital. And if we call that a myasthenic crisis, and many times those patients need to have mechanical ventilation, and they need to be treated with other stronger medications called immunoglobulins and also plasmapheresis, which is sort of similar to a dialysis treatment. But those are specifically used and typically used in myasthenic crisis when the patient is doing very bad. So.
No. Well, it's good to hear. So we've learned about myasthenia gravis, the progressive fatiguing weakness. Now, at least I'll know what it is. Progressive fatiguing weakness of the eyes and even of the proximal shoulders. And then there's good treatment and good prognosis.
Correct.
All right, good. So now, the next topic we want to talk about is Guillain-Barré. Guillain-Barré. What is Guillain-Barré?
Guillain-Barré is also an autoimmune disorder, but in this case, those antibodies that are created by your body, so they attack the nerves, not the junction between the nerves and the muscles. So typically, there is a viral infection. The most common one is the Campylobacter infection. It happens more in Asia, but in the U.S. and Europe, we have other type of viruses that also can trigger the disease. So what happens is that when you get infected with the virus, then your body reacts producing antibodies. But sometimes there is this, what we call molecular mimicry, meaning that those antibodies think that your nerves are actually the virus they need to attack.
Wow.
So in that case, They attack the nerves, and patients start developing weakness, numbness, tingling, and sometimes it also can affect the muscles of respiration, and they can go very quickly downhill and end up in mechanical ventilation as well.
And what's the time period between the viral illness and the Guillain-Barré syndrome?
Typically 3 weeks.
Oh, so it's not like I had the viral illness 3 years ago and now I have.
Typically the infection occurs between 3 and 4 weeks, mainly 3 weeks, 19 days if you want to be more specific.
Wow.
But many times there is no one that can recall that actually a viral infection occurred. But it has been demonstrated that the virus is there when you do viral studies.
Oh, so you don't even know that you really had the viral infection?
Correct. Many patients don't. I mean, in my experience, many patients do not know that they actually had an infection in the past, but some do.
Okay.
The other cause could be, or less likely associated, for instance, stress, surgeries, but there are medications now that we have to be aware of. And I have seen a couple of patients in my practice with this problem. So these medications called checkpoint inhibitors that are anti-cancer medications that essentially have revolutionized the treatment of cancer, especially in advanced patients. And there is a medication called pembrolizumab that is very commonly used now in the oncology world. And we have seen a fair amount of patients that can present with myasthenia gravis, as I mentioned before, and also with Guillain-Barré, with the type of Guillain-Barré picture.
And how does the medication cause it? It's an autoimmune condition, right?
Correct, because those checkpoint inhibitors, what they do is that they essentially avoid the restriction of the immune system to attack the cancer. So you essentially release your immune system to attack the cancer with those medications, but it carries the drawback that it can actually trigger an immune response that can affect your nerves.
Wow.
So it's a
little complicated,
Yeah,
huh?
exactly. Right.
Very complicated. Okay, so how does somebody know if they're developing Guillain-Barré? What are they feeling?
Right. One symptom that I find very common is low back pain. And this confuses everybody, including the patient and also the physicians when they go to the ER. So they think that the patient has a low back issue, a disc herniated, because what happens is that Guillain-Barré affects the nerve, the peripheral nerve, but also the nerve roots. And the nerve roots are very close to the spine. So in the lumbar spine, we have nerve roots there. So they get swollen and they cause pain. And then after that, they develop this, what we call paresthesias, which means numbness and tingling of the fingers and the toes. So when you have a patient with low back pain, numbness or tingling in the toes, you need to start having a high index of suspicion that the patient might have Guillain-Barré. This is very early, though.
Okay.
The most prominent finding is that they have weakness in the legs. So the classical patient says, you know what, I was trying to get up from the chair and I couldn't. And it's because they have weakness in the proximal muscles. And that is a very common term that you probably have heard in the hospital, ascending paralysis. Mm-hmm. So ascending paralysis doesn't mean that the weakness starts in the feet and then ascends to the calves and then to the legs. No, that means that the legs are affected more prominently and earlier than the hands and arms. So that's what ascending paralysis means. So legs first, then arms, then respiration. But it can also start in the eyes. We have muscles in the eyes too. It can also start in the muscles of the swallowing, the speech, and also affects the respiration. So there are many different varieties of presentation, and it can confuse, as I said, everybody. So these patients may come and then the ER physician thinks that they have a stroke. And then we start doing the MRI, and eventually the MRI is negative, and they say, what's going on here? And the patient has weakness everywhere. So then you have to think about Guillain-Barré right away.
So you told me the time period, 19 days from the viral illness that we may not even know that we have to the Guillain-Barré beginning. But from the moment that I have the back pain, I start getting numbness in my fingers, I start having difficulty standing out of a chair. What is that time period? How long does Guillain-Barré take to progress like that?
Typically, for the diagnosis to be made, they progress between 1 and 4 weeks. It should not progress more than 4 weeks. If it progresses more than 4 weeks, then it becomes another disorder that is called CIDP. It's a chronic condition similar to Guillain-Barré, but this condition is lifelong. But Guillain-Barré should not get worse after 4 weeks. But they can either worsen over this 4-week period, or they can worsen from today until tomorrow.
Wow.
So it can be very fulminant, the disease course. So that's why we should have a low threshold to admit those patients to the hospital when they have this suspicious presentation.
And so how do you guys, whether you see them in the office or you admit them to the hospital, how do you make that diagnosis of Guillain-Barré?
Right. Clinically is the most important one, especially when the MRIs are normal. Let's say you do an MRI of your brain, the MRI of the cervical spine, the MRIs are okay, they are normal, the patient is very weak. So then I start thinking about Guillain-Barré right away. And the second part is to do a lumbar puncture with a cerebral spinal fluid analysis. And the typical finding there is something that we call albuminal cytological dissociation, meaning that there is a high amount of proteins in the spinal fluid with minimal amount of white blood cells. What happens here? That the first week, the spinal fluid can be normal. So you cannot let yourself go and say, no, the patient doesn't have Guillain-Barré because it's normal. And then you might have to actually repeat the spinal fluid within 2 weeks because by the second week, 90% of patients with Guillain-Barré will have an abnormal spinal fluid. So what I typically do, if I have the capability to do this, is as soon as a patient comes in, then I do an EMG nerve conduction studies, if the hospital has that capability. Because the EMG nerve conduction studies can give me an idea that the problem is in the peripheral nervous system. If I have a severe patient with severe weakness, and I have an abnormal EMG, this is Guillain-Barré. I have to treat it as such, even before the spinal fluid examination.
Wow, great. And so let's talk about the treatment. So what is the treatment for Guillain-Barré?
The treatment is similar to the myasthenia gravis crisis.
Okay.
So
because they're both autoimmune conditions, is that
Correct.
why? You're attacking the immune system.
Correct.
Well, you're trying to decrease the immune system, which is attacking the body.
Exactly.
Okay.
So we use either immunoglobulins or plasmapheresis, what we call is plasma exchange. My preference is plasma exchange for both disorders, especially if they are severe, because it starts faster. It's a faster action than IVIG or immunoglobulins. But they have both demonstrated they're effective and they're equal. It just depends on the preference of the physician that is treating the patient, the cost, for instance, the patient's preference, the complications, comorbidities. They have, adverse events. For instance, we cannot use immunoglobulins in a patient that had a stroke or a blood clot in the past, or if they have kidney failure, for instance. Plasma exchange should not be used in patients that are more prone to infections, that they are more prone to have decreased blood pressure, etc., or anemia. So
that's why medicine is not in a recipe book.
Correct.
It's incredible. All these different factors that go into making a decision of what's best for the patient.
I try to be very straightforward whenever I face any kind of disorder, but you have to accept that you have to consider all possibilities, and 2 + 2 does not equal 4.
No, not all the time. Okay, so you told us in myasthenia gravis, the prognosis is excellent. How is it in Guillain-Barré?
Guillain-Barré, many patients, let's say more than 80% of patients, they retain the ability to walk by the first year. So I always tell the patients, be patient, okay? Because this is a long shot, a long road here to go. So I would not say, don't get discouraged if you feel that after 8 months, you're still not back to normal, because let's wait a year and see what happens. But 80% retain the ability to walk, and 50% actually can recover completely. But there are some residual deficits that can remain, for instance, numbness, some difficulty with balance, some weakness in the hands and feet, etc.
But it's overall pretty good.
It is overall pretty good, correct.
Okay.
Especially if the patient is not too elderly. For instance, the case was not severe to start with. And if the patient did not require mechanical ventilation, so put on a breathing machine, then the prognosis is better as well.
Okay. And then, as if you have a family member, a grandmother, a father with any of these conditions, myasthenia gravis or Guillain-Barré, is it hereditary? Is it passed on?
No, it's not hereditary. And so when we have a patient with myasthenia that the patient said, I have a family member that have a similar condition as I do, then I start thinking that the problem might be a muscle issue. So we call it a myopathy, not myasthenia. Myasthenia is not hereditary, and Guillain-Barré is not hereditary.
All right. And then let's talk about vaccines and these conditions, because a vaccine develops or creates an immune response. For our viewers, when you get a vaccine, whether it be a flu vaccine or a COVID vaccine, that creates an immune response to defend you against the flu or against COVID. But that immune response, can that impact these autoimmune conditions that we're talking about?
Not typically. So this applies mainly to Guillain-Barré. Okay. During the 1976 and 2009 H1N9 pandemic, there were cases that of Guillain-Barré that were seen that made the physicians suspect that it could be an association between the vaccinations and the presentation of Guillain-Barré. But it was demonstrated that in the 2009 H1N1 flu pandemic, the patients that were vaccinated did better, meaning that there were less incidents of Guillain-Barré in those patients compared to the patients that were not vaccinated. Okay. So that theory was essentially thrown off. And with the COVID-19 pandemic, there have been no clear indication that it is associated with COVID infection or with the vaccine of COVID for COVID. So now there is a point to be made here. The Johnson & Johnson vaccine, it was found that it had a higher incidence of patients with Guillain-Barré, but not the RNA vaccines, the Pfizer and the Moderna vaccine. So this is a guideline that we typically have recommendations that we tell patients. What I tell patients first is you have more chances to develop Guillain-Barré, you have a flu, than if you actually are vaccinated with the flu. So if you can avoid the flu, you have more chances to not have Guillain-Barré. Also, if those patients had Guillain-Barré after the vaccine, they probably should not have that vaccine specifically, okay? And if they had Guillain-Barré this year, the recommendation is for those patients to wait a year before having the flu vaccine. However, if the patient is a high-risk patient, a patient that is older, or they have multiple cardiovascular disorders, multiple comorbidities that are increased risk of dying from the flu, then regardless of whether or not you had Guillain-Barré, please get the vaccination. You're going to have more chances to survive than the small chance of having Guillain-Barré.
Yeah, so overall, it's pretty safe. The vaccines are safe and they're helpful, and it's been proven there's really no direct relationship. Okay, well, we've learned quite a bit about these neuromuscular disorders, and I want to thank you for coming.
Thank you.
Thank you for spending a little time with us today and giving us the information. And obviously, as I always say, be healthy, be aware, take care of yourself and your family, and if you start noticing that progressive weakness or that numbness or that back pain, bring it to the attention to your healthcare provider. Go see your primary physician, go see your neurologist, and take care of yourself, because obviously a healthy lifestyle is going to lead to a healthy life as well. So once again, Dr. Anthony Gonzalez with Miami Community Health, thanking Dr. Varela for being here with us today. And as always, take care of yourself and your